Good evening, sir.
Good evening, ma'am.
So we will wait for 2 more minutes and then we will start the class.
Good evening, ma'am.
So you can start the class now. Thank you.
Yes, ma'am. I'll be sharing the screen.
Yes, sir, the screen is visible.
Am I audible as well?
Yes, sir, you're audible.
Yes, sir.
Okay. Okay. Some things of this class has already been discussed, so we'll quickly go to that. So initially, my classes I was just focusing on the fractures, but today somewhat management also we will see. So initially, we saw about the clavicle fractures. So some things which you can put it in the chat box. Whenever I'm asking, I no need to unmute yourself. You can put it in the chat box. So why we need to know that clavicle fracture? So first of all, what happens? The incidence rate of clavicle fracture is very less. Most common things of clavicle fracture is seen in pediatric fractures. I mean, in children. So that is why in what happens once they get that fracture, then the healing is also not that difficult in younger population, as we already know. So yeah, fallen and outstretched arm, yes, good. So etiology could be because of your direct trauma or could be because of your indirect trauma. So mostly the common kind of clavicle fracture which affects is the middle third of your clavicle. So directly coming to the treatment, we have reduction, and also they use figure of 8 bandage. Can you see that in that image? Later, why we need to address the things initially, when we don't address it properly on time, there could be sometimes complications. Even though we address, the complications may occur. The complications could be your malunion, but even though malunion is there, there won't be an effect in your normal function. One more kind of thing is non-union. All these are not immediate complications. These are classified under your late complications. So initially they manage through the sling. So why we need to have that indication for operative management? Initially I told you they will be managed through that figure of 8 slings or shoulder slings. Then the indications could be because of your late complications which will develop over a period of time. That could be your non-union neurovascular involvement, compressing a neurovascular bundle, unstable fracture of the lateral end of acromioclavicular joint, a persistent wide separation of fragments, or one more major thing could be your floating shoulder. So severe displacement over a period of time, or you have a multiple Z fragment, sometimes they call it as a Z fragment, could cause a compression. So in case of your floating shoulder also is one of the major indication for the surgical or the operative treatment in case of clavicle fracture. Coming to the scapular fracture, usually no displacement, supported from the muscles of the both the sides. So floating shoulder in the sense, whenever you have your completely your shoulder and your clavicle contact gets disrupted, in such cases is what they need to be operatively managed. So that is in simple terms. So usually there is no displacement support in case of scapular fracture. uh, Sorry, I'll check your chat box once the thing is done, because if I concentrate both it, I will miss my flow. So the thing is the arm sling, and major thing is you have your scapular blade where you have more number of um muscles surrounding your scapular blade. The forces acting there will mostly stabilize, but over a period of time you have a larger forces which could lead to your fracture of scapula. So here is one more indication of your floating shoulder. The major displaced glenoid fracture could be one of the indications in cases of your operative management for the scapular fracture. So next, coming to the fracture of your humerus. So you have your proximal humerus where you have your surgical neck greater tuberosity. I already told the fracture of humerus is divided into mainly three things. Can someone tell what could be the thing? Already did in my slide, but if you remember, can tell what could be the three things where we divide our fracture of humerus.
Surgical, anatomical, soft fracture.
No, that is what you're talking about is your proximal end is divided into surgical. Uh, I'm talking about the humerus in general, fracture of humerus. Yeah, you're right. Partially, that could be your proximal end, mid shaft, and one more thing is the distal end. So it's already here: proximal humerus, shaft, distal humerus. In distal humerus, you have again supracondylar, intercondylar, because that is again you have your T and Y fractures. So all that initial things are done. For surgical neck treatment, impacted strapping has been done. You can see that. Next, you see in displace they do reduction under the uses of general anesthesia. Once the reduction is done, then they do the strapping if this is displaced. If it is an impact fracture, only the strapping would be sufficient. Surgical reduction and fixation with K-wire, plate and screws, intramedullary nailing. These are the various images where they have fixed the surgical neck using based on the severity and the impact. So that is what you were telling, right? The surgical neck, head, and greater. That is the proximal end of fracture is divided again in that. Next, coming to the shaft of humerus fracture, it's could be a stable transverse fracture. Try to managed conservatively. Unstable oblique or communicated fracture, they use open reduction internal fixation. Could be a interlocking IMN plate and screws, medullary nails, and the external fixator. The major thing that has to be observed in case of your fracture of humerus is one of the nerve that could be damaged in shaft. Can someone tell what is a major thing?
Radial nerve.
Uh, you can put it in the chat box.
Radial nerve groove.
Yeah. Then what could be the other? One more. Axillary. Axillary is what I was looking at. Radial nerve. Yeah. Okay. Fine. Those bundles sometimes in a severe cases brachial plexus injury can occur. But here I was trying to think about the axillary nerve is damage in this kind of fracture. So next, internal fixation done for the humerus. You see the plate and screws. Then we have interlocking nailing and malleable medullary nails. So most important complications are already told, radial nerve, and also because of radial nerve, what happens is manifested by your wrist drop, and other complications could be a non-union. So one question, you may be knowing your distal humerus. So and that is majorly comes under your elbow fractures. So you also know that you told one of the reason again in elbow could be your fallen outstretched arm, or could be your other causes. So understanding the basic anatomy of the condyles and the bony landmarks is very important for choosing the appropriate treatment. So thereby we choose that in such complicated fractures to avoid the further complications. So one question for you guys. There are some six ossification. This is not related, but something which you may be knowing, or just to check your thing. Six ossification centers around your elbow joint. Can someone put it in a chat box? I am not required to name all six ossification centers around your elbow joint. I'll give you like 10 to 15 seconds time. Put it in the chat box. What could be the ossification centers? Is someone putting some message? Just checking. Did you understand? Yeah, okay. No, not. I'm not asking proximal, distal. Should be very specific. Yeah, could be there in the proximal. Yes, capitulum. You're right. I'm not asking what are the types of ossification. I'm asking the ossification center. One answer I got. Yeah, olecranon is right. Already capitulum, olecranon. Trochlear. Yes. La Radial head. Yes. Right. Okay, I'll tell you. First one is your capitulum. Next one is your radial head. Then you have your epicondyle, trochlea, uh, olecranon, and lateral epicondyle, medial and lateral both. Okay, so these are the six ossification centers you need to know. That is like even the surgeons also will look after it. So check whether there is a proper healing occurring around this. So supracondylar fracture. What is supra? Supra means anything above the condyles. A supracondylar fracture commonly seen in children. You have your extension and flexion types. Clinical signs is swelling where you can see a clear cut fragment breaking just above your condyles. You can see this is like your elbow joint. See how the just above the elbow supracondylar fracture is seen. Treatment in children, urgent reduction and posterior slab is placed. If again that is unstable, they use percutaneous wires. ORF with wires could be irreducible. In adults, ORF with the what is ORIF? Already
Open reduction occurring.
Open reduction
Open
internal
reduction
fixation.
internal
good, good,
fixation.
good. What I expect you to put in the chat box, that would be great because what happens sometimes the voice is too much. So yeah, you're right. Open reduction interfixation with plates and screws. So complications for supracondylar fracture could be a malunion, altering your carrying angle, cubitus varus, cubitus valgus. That's what joint stiffness due to adhesions and malunion. This is cubitus varus. Try to analyze, compare within the cubitus varus and cubitus valgus, so that time you can understand it better. This is like one homework for you guys. Keep try to get the image of cubitus varus, cubitus valgus, compare it, and see. Also clinically, you take two pictures and compare. Then you can understand again how the biomechanics works. So those things will be interesting for you again when you consider the rehab as well. How that can affect your shoulder and wrist, because any problem in one joint can be affected in your distal and proximal joint as well. So my voice is clear, right? I can getting some echo. Like, is my voice clear and audible? Yeah, okay. Thank you for that. So vascular complications like your acute ischemia due to your vascular injury, edema, and tight cast. How to do the management of urgent reduction for the fracture, release of tight cast and bandage, systemic vasodilators. If no improvement, again you need to do a surgical exploration. Um, so just take a minute or 30 seconds to have a depth of picture. This is one of the anatomical proximal humerus image. So those terminologies is not in that English, but I just found so that so when they do surgically, now there is a lot of advancement happening, but they need to cut open and see where exactly is the things are going wrong. So that arrow which they are showing is your acromion. Acromion is covered by delta. You already know that. So that has been cut open. You can see how they are showing an axillary nerve, coracoid process. Again, your circumflex humeral artery. I mean the posterior circumflex humeral artery. This is one more image. The first thing which the arrow which I am placing is acromion. This is supraspinatus muscle, infraspinatus muscle, teres major, deltoids, and axillary. So when you have the fracture, you know if the surgically they have been operated, you know how the things, how the muscles are flipped and again they are put in back. So based on that, why it is important for us as a physiotherapist to know this, we will be okay. Just can you tell me why we need to know the bony landmarks? Okay, the orthopedician has fixed the surgically. We just have to focus on his goals, right? Why we need to know all this? How the orientation of muscle is important, bony landmarks. Why it is very important? Can put it in the chat box. My question is like you have this bony landmarks, muscle orientation, and all. This is very important for an orthopedician when he does surgery. But for us, yeah, why it helps us to understand what exactly? I want something very specific answer. Yeah, it definitely helps. It's always good to know new things. Yes, one of the
Yeah.
major thing is preventing the complication during treatment. You're correct. Majorly, why we need to know is we need to plan our rehab. So we what we will be thinking now. Imagine re-education of muscle. Very good. That is there. What we need to see is now imagine you have any fracture. I'm just giving one example. Why I put image? Now you have your proximal humerus fracture. See how many surrounding muscles are affected there. So their function could be compromised. So once we do the treatment, we need to focus and target them. Here I'm not going to tell detailing how we need to target them, but that is why we need to know, okay, this joint is affected, this area surrounding, these are the muscles. Okay, these could be your ligaments, or these could be your structures, could be surgery and put back in place. So their strength again could be compromised. So we as a physios, we need to know how to get back individually or train them in a group way. So that is why we need to know the muscle orientation and surrounding bony landmarks around us things. This is one more image, bit zoom image. See how many supraspinatus, infraspinatus, teres minor. Okay. Next thing we have is our forearm fractures. So forearm is biomechanically a very complex unit, not just about the two bones. There is a movement happening. What happens? Radius rotates around L now. Why it is? If Because if radius rotates at L now, what is the movement we are expecting? Can you tell?
Nation and supination.
Very good. Supination and pronation. Why it is important?
Sir, in day-to-day activities, lots of movements we do in pronation and supination, like opening the door,
Very
and while
Yeah, you're right. We need the supination and pronation range. You may be knowing in case of forearm fracture, this is compromised. You know how it is affecting. Exactly. What is the thing is, most of your wrist load is bared by this movement, supination and pronation. That is why it's very important to know. So we know that ulnar bone provides stability, acts as a hinge at elbow. We have your interosseous membrane. I'm not put that all things in the slide, but it's always good to know. It transfers load from your radius then to ulna, maintain the spacing and alignment. So you have your proximal radio ulnar joint, and next you have your distal radio ulnar joint. If there is even 1 or 2 millimeter displacement, this is something what the research tells. 1 or 2 millimeter displacement, or millimeter I'm talking, I'm not talking about a centimeter. There could be a major loss in your rotation or the major compromise in your uh, elbow joint. One of the major complications that is seen in elbow fractures or forearm fractures, can you tell me what it is? Because of immobilization. I can tell you to join the dots. Because of immobilization, what could be a major, one of the major oh, can you please put in the chat box? Yeah, atrophy, malunion and all is right. Major thing is what I was looking for was stiffness. Stiffness is a major thing which develops. Yes. I'm talking about a later over a period of time, not immediately or after. This is like I'm talking about a delayed. So
Cross union.
yeah, cross union could be, but we consider majorly because stiffness. Just consider the aspect of stiffness. So initially, if we would have mobilized that distally or proximally away from the fracture site, the stiffness won't occur. Contracture, you're right. So forearm acts as a functional ring, and disruption of one side affects the entire unit. You know that one supination pronation affected one distal, it can affect your distal radio ulnar joint, and then it can affect your wrist joint as well. So forearm fracture includes fracture shaft of radius ulnar fracture of, it's called as both bone fractures. You have your classification: proximal one third, middle one third, and distal one third. So one of the thing is your nightstick fracture, isolated mid shaft diaphyseal ulnar fracture resulting from the direct blow. Treated mainly by using your closed reduction, and also um, conservatively could be done using your, conservatively they could be done using your cast application as well. So one more kind of fracture, we have your Monteja fracture, proximal middle third ulna. I already had told you initially, just bit, but what is very important here, each terminology is very important. That day also in my X-ray classes, I was giving you some questions. So you were generally telling about shaft, where proximal shaft, distal one third. So here, to know this fracture, to differentiate each fracture, you need to know the each terminology. If you skip one thing, if you just say proximal third, it's different. Proximal middle third ulnar fracture with dislocation of your radial head could be a correct definition for your Mantager fracture. Radial head may be dislocated anteriorly, posteriorly, or laterally. In some instance, both radius and ulnar fracture. We call it as both bone fracture. Next one we have is your Galeazzi's fracture. Before going to the Galeazzi's fracture, I'd already told how important it is for us to know that the distal radial ulnar joint movement, proximal ulnar joint, and I'd also already told that some millimeter difference could affect your major thing. So you already told you have your major activity like eating. So all these activities, not only your gross arm movement effects, also your fine motor skill effect. Your fingers may be fine, but your distal or here it's affected, you can't do it just with your fingers. So that is why how important it is to address that fracture. So coming to the Galeazzi's fracture, distal third radius fracture with a disruption of your radial ulnar joint. So this is the image where you can see fracture to the distal growth plate of ulna. So next we have your Colles fracture, extra-articular or intra-articular distal radius, clinically described deformity, a very classic one you maybe already discussed, dinner fork deformity, what we see here. Mechanism: fall on an hyperextended or radially deviated wrist with forearms pronation. Next we have Smith's fracture. If you know one fracture, it's opposite of this, reverse Colles. Here distal radius with volar angulation or volar displacement of hand and distal. Mechanism: again fall to a flexed wrist with forearm fixed in supination. Unstable pattern often requires open reduction and fixation because of difficulty in maintaining the closed reduction. So in bio in talking about the biomechanical aspect in Monteja fracture, for first we discuss. So majorly the biomechanics, what it alters: ulnar fracture, which alters the radial head alignment because everything is correlated there. Complications: chronic disability can occur over a period of time. So that is why I told initially they will tell you to do immobilize, but what we can do, we can advise them to do initially at least basic of isometrics, if rather than keeping it. So I told you over a period of time it will develop for stiffness. So rather than that, we need to do even though we may not focus on the mobility, we should focus on the elbow stability exercises. So Galeazzi, I told you it has to be addressed. It's requires surgery most of the times because a distal radio ulnar joint instability cannot be maintained or treated just by the conservative management. So next we have Smith's, which is reverse of Colles mechanism. I already told, and disability and difficulty in maintaining the closed reduction. Next we have a Barton's fracture, dislocation or subluxation of wrist in which dorsal or volar rim of distal radius is displaced. Mechanism: fall on a dorsiflex wrist with forearm fixed in pronation. Unstable fracture requires open reduction and internal fixation. So, which movement is mostly required for writing or typing? Can you tell me? Is it pronation or supination? Just some
Main pronouncement.
pronation. You're right. Pronation is the right answer. So, we as a physio over a period of time, if there is a less range, what we can do, we can go some of the techniques. I'm not putting the slides. We can go with the mobilization with movements. It is one of the school of thoughts, MWM, or joint glides we can give. So, what are the muscles we can strengthen around the forearm fractures? Could be your pronator teres, quadratus, supinator, biceps. So, just strengthening a group of muscle won't help. Isolating and strengthening them, and also implementing the functional activity would be your go through as a physio protocol. Not just focusing on the mobility, we need to also focus on the stability, because over a period of time, that stability doesn't come mobile, fracture reoccurrence can occur. So that is why it's very important. Preserve hand and wrist function. Already I told you, realignment of normal osseous anatomy, promote bone healing, allow early finger and elbow range of motion. So we have to gain range of motion. I already told you it has to be in the smart goal format. Okay, options for treatment, you have your casting, long arm or short arm, sugar tongue splint, is one of the thing. External fixation, joint spanning or non-bridging, percutaneous spinning. Then we have our internal fixation. These are various options that is there, and the treatment is again based on the fracture again, impact of the fracture, and the functions which has been compromised. One of the image how the fixation is done. Percutaneous spins. Next, coming to your scaphoid fracture. Scaphoid fracture may occur at any point of the bone. Unstable fracture displays more than 1 millimeter. Stable fracture occurs without the dislocation. So again, the rehabilitation objectives here is to range of motion, restore and improve RM, muscle strength. So here because of scaphoid, you have it's a small bone carpal where it gets fractured. You have a lot of muscles surrounding or attaching around it, so you need to restore and improve. That is you will be having some function, but that won't be enough to stabilize the thing, so that it has to be improved. So it needs a lot of sub appreciation of each muscles and then activating it. That is very important. Functional goal to improve your power grip, grasp, activity associated with thumb movement. You may be having your already in biomechanics, you might have studied about your prehension and power grip. So using those concepts, you can go through how we can improve individually based on that. That would be interesting. So method of treatment, cast, thumb spica cast immobilization is a treatment for choice for non-displaced scaphoid fracture. Open reduction and internal fixation mainly used for displaced, non-union, delayed, and in fracture. So coming to the second topic, we have a stress sharing device and stress shielding device. Stress sharing device, what is the definition? Devices that allow the bone to share the load along with the implant. So the word sharing, already. Um, sorry, yeah, just devices that allow the bone to share the load with implant. That is the thing. Sharing is it is bone is taking some load along with your implant. That is very important. Whereas in stress shielding, one more thing, the entire load is taken by the implant or the fixator what is being used. So mechanism, load is distributed between the bone and implant. Bone continues to experience your physiological stress, promotes natural bone healing, that is your callus formation. Biological effects, stimulates osteogenesis, that is your bone formation, prevents bone weakening. Examples for your stress sharing device, intramedullary nails, external fixator, bridge plating, or biological fixation. So what is the key point observed here is the bone remains actively involved during your load bearing. So you might have heard about your Wool's law. Can someone tell what is Wool's law? Put in the chat box.
Yeah, healing of stress and bone. Strain is required for the bone healing.
Better put in the chat box, please. What is Wool's law? Someone has put. I'll definitely address the your question how to write for 17 at the end of the class. Amount of stress proportional to the osteoblastic. Yes, bone and simple thing. Bone adapts to the stresses placed upon it. Yeah, that whatever you put is right. Thank you. So it also Wool's law application takes place in this. So what is the thing is early weight bearing is one of the advantage, faster return to function, because we are involving the bone, we are not keeping it very safe and very protected manner. So bone itself is involved in the healing process along with your stress sharing device. So that is very important. uh, Next thing is your stress shielding device. So devices that take most or all of the load. Sometimes there will be some amount of load, but most to all is what we can say, reducing the stress on the bone. Mechanism: implant based the maximum load, bone experience reduced mechanical stress. Biological effect: leads to bone resorption due to lack of stress, can cause weakening of bone over a period of time. Bone remodels across stress, and considering the Wool's law here, according to stress, less stress, bone loss. So both way we can try to imply. So examples: rigid compression plating, some joint processes. Key point what we need to observe is bone becomes passive, implant dominates the load bearing. So before coming to this definition, if I have a young individual, what kind of device I can put, whether it's stress sharing or stress shielding?
Stress sharing.
Okay, why? Put it in the chat box. Why we can go with the stress sharing device? So again, one more thing: if you have your complicated fractures where you have a lot of fragments where the bone healing is there, or you have a prejudice, comorbidities which is already delaying your bone healing, then again, even in the young individuals, we may be choosing stress shielding device. What about your old individuals? What kind of device we will be using?
Stress shielding.
Why?
इसका bone formations capacity lose हो जाता है.
Yes, you're right. Bone, the amount of stress taken by bone in that age, because already they normally only they can't take the load, and using this thing, we expect them, and that healing takes sometimes again based on the bone health. They may go with the stress sharing sometimes based on the thing and how exactly is the goal that is there, that differentiate based on the orthopedician point of view as well. So coming to your quick difference, so stress sharing, load bearing is shared between bone and implant. In stress shielding, mostly by the implant. Bone activity is active here because we are involving the bone, and mostly it is reduced. We can't say completely nil. Sometimes there would be your bone activity but reduced. Healing type is callus formation. First one is stress shielding is by direct healing. Bone strength maintained or improved. Here may decrease because you're not involving the bone, because the load is again fully put on the implant. Risk: less bone resorption. Here higher bone resorption. Example: intramedullary herring. Here it is your compression plates. These are your some of the uh, stress shielding device, your compression plates, your implants, which the entire, you see this here, the entire bone load is taken by the implant only. And here you see in the total knee replacement implant, this is a total knee replacement implant. You can see how many areas of load it has been taken. Like these are the numbers where they have put the implant takes over the load of the bone. This is your stress sharing device, your external fixator device type. Again, you know, callus formation, speedy recovery, fast. There would be some of the challenges for us physio, because this again is very heavy, very painful. But functionally, if we consider, this is sometimes the choice of treatment. Disadvantage, print tract infections, or some of the other disadvantages could be there. Open tibial fractures, severely comminuted distal radial fractures could be some of the things they are focusing that has to be there. Just give me a minute. Okay, what could be your according to the recent advancement, what we can tell is, um in cases of your stress shielding devices, they are moving towards the porous titanium to reduce the stiffness. Whereas in cases of your stress sharing devices, they're using the bioabsorbable alloys, or these could be some of the things. Is something good to know things. Next slide, I'll be putting some of the materials or what they'll be seeing. Am I audible?
Yes, sir. But please on your camera, sir.
Oh, now it's fine now.
Yes, sir.
Oh, coming to the clinical significance, as a physiotherapy perspective, stress sharing device, early weight bearing often encouraged. Functional rehab is faster, better long term bone strength. Whereas in stress shielding may require protected loading initially, risk of implant dependence. Careful progression needed to avoid bone weakening. So these are all some of the things that has to be taken in a physio perspective view. This image I tried to put, but still not clear. So how the fracture healing occurs. Just look at, just focus on the red line. So here there is a natural force transmission here. Here there is a stiff device placed. The force transmission comes straight along the device. Then based on the device, how the force transmission distributes is something good to know things. So again, if the bone takes the load, the healing is faster. You are completely dependent on the implant, the bone weakening can occur, because you know you are not putting any load on the bone. So more so that goes again to the reverse of Wool's law. Use it, and again comes in the picture, use it or lose it principle comes in picture here. So these things what I put here is various internal fixator that can be used. In cases of your head, skull fractures or craniofacial, they use wires, pins, plates. In cases of your trunk, they mostly use your that is your clavicle, scapular, pelvic, spinal fracture, intermedullary nail screws, external fixators. Fixation device consists of your rods, pedicle screws, plates, etc. In cases of the upper limb fracture, excuse me, humeral fracture, radius, ulnar, metacarpal, phalangeal fracture, open reduction with plate, closed reduction intermedulla nailing, closed reduction with intramedulla nailing again. So close reduction with external fixer. This could be a various surgical methods that can be used. So in cases of your lower limb fractures, you have your open reduction plate, screws, closed reduction intermedulla. Again, most of the things same, but what happens here, based on your function, and again I told you based on the impact, again your surgical method goes varies, and again it's purely a surgeon point of view where he takes the call which one has to be done. So biomaterials for internal fracture fixation could be your cyclic loading, maintain the mechanical stability, allow functional bone healing. Main classes of biomaterials used could be your metals, most commonly used polymers. These are some of the things that has to be known. I just put one metal, it's one of the gold standard thing. You have your titanium alloys, which is like advancement, and you have most of your biodegradable things taking place. So comparing between titanium and stainless steel, elastic modulus, you have your lower or closer to bone, higher strength moderate, but stainless steel is high. Fatigue resistance is high, because if you compare in both, there is disadvantages and advantages. Fatigue resistance high in titanium, but stainless steel is moderate. Corrosion resistance, thick oxide layer is there, slowed oxide layer is, I mean, regeneration. So sometimes considering the most win-win situation, titanium they consider. So based on the Wool's law that I already told, stress shielding, bone resorption, titanium is prepared, which reduces the stress shielding. Stainless steel stronger but weaken the bone over a longer period of time. Stiffness graded rates, high stiffness at the fracture site. So what happens? Helps in reduce the stress shielding and maintain your bone loading. So these are few things I thought I'll discuss in the end. So these are your delayed complications. So delayed union, non-union, malunion, cross union. So delayed union of your upper limbs is sorry 4 to 6 weeks. Union of your lower limbs is 8 to 12 weeks. Any prolonged time more than this is considered as delayed union. So again it depends. This is not like a perfect thing, but once the orthopedician will expect, okay, union will occur based on your complicated fracture, we will be expecting more than that time, then they will consider this complication delayed union as occurred. So what is delayed union? When a fracture takes more than the usual time to unite, it is said to have gone to delayed union. What could be your causes? Inadequate blood supply, infection, incorrect splintage, could be your excessive traction. We are allowing the bone. What happens? You have a fracture. Why we keep it like too much of load won't be there. But if you do again the excess traction, there will be again too much of load or stress put on the bone. So again, it could be your union of fracture delays. So factors of biological or biomechanical, biologically poor blood supply, severe tissue damage, infection, periosteal stiffing could be some of the factors which will lead to your delayed union. So mechanically over rigid fixation device, imperfect splintage. What happens is you have your, I told you, one of the thing is your rigid compression plate, which is taking the complete load. One of the example for your shielding device. So here what happens, you're not put very rigidly over a period of time, the unitation won't happen, it will be delayed. So again, one of the thing is improper splintage, excessive creates the gap or delays the ossification in the callus formation. So signs, the fracture site is usually tender, the bone may appear um move in one place, however it is subjected to stress, the fracture is not consolidated, the fracture site is clearly visible. These are all the factors. If they pile up and clusterly, we can consider okay, the bone is still undergoing under delayed union. So that's how we can consider that. So clinical features: tenderness persist, acute pain if subjected to stress, X-rays visible line fracture, very little callus formation of periosteal reaction, atrophies. See here you can see there's still, yeah, there is some amount of callus, but you can't appreciate. Again, depends on how the fracture was initially. You need to compare. Okay, sometimes the fracture will be too much. Okay, there could be some amount of healing. Then we can't consider it is very delayed or in. So based on the first fracture X-ray, and after some, okay, maybe 8 weeks or 4 to 12 weeks, we are taking the X-ray. Then we need to compare it. Just having the post X-ray and telling that okay, the fracture is not inherited becomes sometimes unrealistic. So what could be your risk factors? I told you these are some of the complex. What could be your risk factors personally could lead to your delayed union? Can you put it in a chat box? Risk factors because of delayed union. Infection, very good. Smoking could be one of the thing. Diabetes could be one of the thing. So what we need to do is we need to improve the circulation in around, yeah, poor blood supply. Correct. That's why it was telling we need to do the circulation, avoid excessive loading. So that is what we can do. Treatment: plaster should be sufficiently extensive and must fit accurately. Replace the traction by plaster splintage. I told you too much of excessive traction is not required. Use of functional bracing. Operative: bone grafting with or without fracture. Delayed non-union is one of the one more. Uh, I mean, delayed. I already told non-union. When a fracture takes more than the usual time, that is called as delayed only. So it doesn't occur at all. You can't see any kind of thing. Then it is called as non-union. That's how we differentiate. So uh, if it is an atrophy, we consider as a biological failure. If it is again because of hypertrophy, that is a pathology. What could be involved? I'm talking that could be your mechanical failure. So in cases of your hypertrophy is seen, we need stability. In cases of atrophy, bone grafting. Causes: old age, associated systemic illness, distraction at fracture site. So already someone told about the muscle pulling fragments. Example, the patella gravity and the shaft of humerus. Soft tissue interposition, bone loss during fractures. That is in case of your open tibia fracture, one of the example. Infection from open fracture, example tibia. Damage to the blood supply of the fragment. Scaphoid fracture could be one of the example. Pathological fracture, osteomyelitis in tibia. So causes related to treatment. These were the causes related to patient and causes related to fracture. Next, we had causes related to your treatment. Inadequate reduction, fracture shaft of the long bones. Inadequate immobilization, fracture shaft of the, again example of long bone. Distraction during treatment, that is not the normal one, the excessive one. The shaft of femur could be one. Atrophic and hypertrophic, I told you. Atrophic is again the biological thing. Hypertrophy needs the stability. Callus is present, but it does not bridge the fracture site. So you are focusing more on the stability. Here in atrophy, there is no callus formation at all, or there is no initiation at all. So then we need to do that bone grafting. Common sites: neck of femur, scaphoid, lower third of tibia, lower third of ulna, lateral condyle of humerus. Clinical features again: pain, deformity, abnormal mobility, refracture. Radiological findings: delayed, inadequate callus, visible fracture line, non-union, ends are rounded, smooth, sclerotic. These are one of the classical signs we need to observe. Medullary cavity may be obliterated, visible fracture line. Again, this is one of the things. Treatment for most commonly conservative. Bone grafting, I already told you. When the process of fracture healing This I already told you, fracture healing comes to a stand before its completion. The fractures have to go on to a non-union. So it is not before the 6 months the fracture can be so labeled. So here initially we were talking only with few weeks, then we call it as delayed union. So for 6 months nothing is happening, then we can label it as your non-union. So non-union is developed as the first it is called as delayed union. Then over a period of time it develops for a prolonged period of time. Then point it is called as non-union. The injury could be a soft tissue loss, bone loss, intact fellow bone, the bone, poor blood supply, poor hematoma, infection, and pathological lesions. So presentation again, pain at the fracture site, non-use of extremity and tenderness, movement around the fracture site. Investigation again, we need to focus on the presence or absence of callus, lack of your progressive suggested that there is a callus formation, but you are not appreciating any changes, or the fracture line fragments are getting closer. So that has to be seen. Closed medullary cavity suggests again non-union. Radiologically, bone look inactive, suggesting the area is avascular. That's why we need to know that atrophy and hypertrophic non-union. This is like a example of non-union where bone grafting is needed. So treatment occasionally occasionally it's symptomless, needing to the treatment. Functional basing may be sufficient to induce union. Electrical stimulation promotes the osteogenesis. Operative, very rigid internal fixation with hypertrophic fixation is required here. Treatment again, bone grafting most of the thing, and they use Elizaro's method also one of the thing. Non-treatment when there is no disability, example of scaphoid fracture. Elizaro's method is that ring fixator method. I think you were already knowing that. So one more thing, the last thing, that is malunion occurs when the bone fragments join in an unsatisfactory position, usually due to the insufficient reduction causes primary fracture was never reduced and has united in a deformed. So initially that is a orthopedician or a goal to reduce the fracture. It has been not done or not addressed, then high chances of going for a malunion. Shortening is of course one type of deformity is what we see. In secondary malunion, the fracture was reduced, but the reduction was not held or not maintained. That is the thing. And redisplacement may occur during the first week, and check X-ray of first week is advisable. We need to see whether the uniting or some changes are occurring, or it is reduced properly. That has to be seen. So later we check and the malunion has already occurred, then it becomes difficult to address it. The fracture does not unite proper position said to be malunited, improper reduction, unchecked muscle pull, excessive communication. All these things has to be addressed or could be the causes when you're not addressed properly. Consequences, deformity of shortening of limb, limitation of movements. So it directly affects our functional aspect. Treatment osteoclasis, that is refracture done in children to correct mild to moderate angular deformities under general anesthesia. Redoing the fracture surgically, most common open reduction interfixation done along with the bone grafting. Corrective osteotomy site from the fracture, example in cases of supracondylar or excision of protruding bone. No treatment is necessary if the remodeling is occurred. Signs, deformity which is clearly seen. There may be painful limitation of your joint movements at elbow. Valgus deformity may be present with delayed ulnar nerve palsy. Treatment, I already told you, osteotomy is in operative management. Conservatively, shortening of may be featured a raised shoe. That what we can do without touching the operative management. We can modify our shoes, or that could be there. But again, for some period of time, it will be helpful. But for a prolonged period of time, keeping those things, it will be very challenging for the person. So that is why we need to be very careful. So this is one last thing. Cross union is a special type of malunion which occurs fractures of forearm bones wherein the two bones unite with each other. When radius and ulnar fractures are joined each other by a bridge callus, it is called as cross union. It is likely to develop in the case where two fractures are at the same level. It results of complete limitation of forearm rotation. I already told you some moment of displacement which is not addressed around your millimeter could lead to your severe compromise in the forearm rotation. So this was a last slide. Someone had asked about the goals. I'll just check through that. To ask something like 7 marks, 7 to 15 marks, na something. I'm trying to get that question. Can you repeat your question? I'm trying to get it, but हाँ. ओके. शॉर्ट टर्म और लॉन्ग टर्म गोल पूछते हैं 7 to 15 मार्क्स क्वेश्चन में. तो आप जरा एक क्वेश्चन का एग्जांपल बता दीजिए. इसके हिसाब से मैं बोलूंगा कैसे लिख सकते हो. शॉर्ट टर्म, लॉन्ग टर्म, एक एग्जांपल बता दीजिए. कौन सा क्वेश्चन पूछा था?
Thank you, sir.
Yeah, the person who, yep, someone. Cubitus varus, first you need to know what is your carrying angle. So based on that, if the decrease in the carrying angle, then it is known as your cubitus varus. Increase in the carrying angle, it is known as cubitus valgus. So normal carrying angle would be around long term goals. Okay. Tell the long term, short term goals for college fracture. So firstly, what we can not an issue. I will explain with इसके हिसाब से college fracture. पहले हमें जरा आउटलाइन ऑफ द फ्रैक्चर लिखना है. कोलिस फ्रैक्चर मैंने ऑलरेडी बताया. डायरेक्टली वी कांट जंप विद द गोल्स फॉर 15 मार्क्स. सो दिस इज व्हाट आई कैन टेल. फर्स्ट गिव एन आउटलाइन. आप आउटलाइन दे सकते हो लेकिन उस पर ज्यादा स्ट्रेस मत दो. साइंस एंड सिम्टम्स इन्वेस्टिगेशन, थोड़ा आउटलाइन मे बी. उसके बाद में आपको उसका गोल्स लिखना है. पहले शॉर्ट टर्म, लॉन्ग टर्म गोल्स. अभी मैंने बताया था, कुड बी योर पेन. कोलेस फ्रैक्चर में किधर पेन होता है? सो आपको पेशेंट को इमेजिन करके ओके आप एक कोलिस फ्रैक्चर आदमी आ गया. सो उसको डिनर फोक डिफॉर्मिटी है और कुछ और चीजें है. उसके हिसाब से आपको पहले लिस्ट डाउन करना है. व्हाट आर द इमीडिएट थिंग्स आप एसेस करते हो और एड्रेस करते हो. उसका दर्द है, मूवमेंट्स है, वो हो सकते हैं उसका शॉर्ट टर्म गोल्स. और नेक्स्ट आपको लॉन्ग टर्म गोल्स को एड्रेस करना है. long term goals like your musculoskeletal endurance or your full complete functional range up, not just a normal range, complete functional range could be your thing. So pain could be one of the short goal. पेन के हिसाब से क्या क्या ट्रीटमेंट दे सकते हो. आपको एक्सरसाइज के अलावा भी लिख सकते हैं. Patient education, you can divide into three things. For example, you can tell them based on your exercises, based on your patient education और based on your modalities. आप इस वजह से तीन डिवाइड करके थोड़ा इलैबोरेटली लिख सकते हो. एक काम कर दीजिए, मैम के साथ मेरा नंबर है. आप एक बार एक आउटलाइन लिख कर मुझे सेंड कर दीजिए. कोई पॉइंट्स ऐड कर सकते हो, उसके हिसाब से मैं जरूर बता सकता हूँ. क्योंकि अभी मैं एक थोड़ा आइडिया, सिर्फ आइडिया दे सकता हूँ. So that is the thing. Then with your long term functional goals है आपका इस हिसाब से. Okay, we can focus on that. Like your person is going for a work, they may be giving some scenario, right? Or getting back to the work. So what are the functional treatment, in hand, what are the activities? So how you can give for a prolonged period of time, his fine motor skills is fine or not. उसके हिसाब से आपको पहले उसका clinical science you need to understand. Okay, patient Colles fracture means a signs and symptoms easily will be there. So based on that, you link with your goals, short term and long term. Then you can tell. Yes, ma'am. I think we can wind up the class.
Yes, sir, sure. Whosoever wants to ask the question, जिसने भी सर जिसको भी बोल रहे हैं, आज की लिंक जो है वो मैंने ही सेंड किए है। आप उसी नंबर पे मुझे क्वेश्चन भेज दीजिएगा, मैं सर को फॉरवर्ड कर दूंगी। ओके।
Thank you.
ओके सर, थैंक यू सो मच फॉर द क्लास सर।
Thank you, ma'am.
Thank you, sir. Good night.